Hello and welcome to this session of MD310 Medical Care Provider. In this session we cover initial assessment and immediate interventions. By the end of this session you'll be able to list in correct order 4 actions that you perform before you even make your initial patient contact and do your initial patient assessment. You'll be able to define the mnemonic AVPU, AVPU, in the context of your initial assessment. You'll list in correct order the 7 steps of performing the initial assessment, including the assessment and interventions of each step, and you'll be able to perform a 7-step initial assessment with interventions. This was actually covered in a lab section as well. Anytime you approach a scene where there's a patient, no matter what that scene is, you always have to think of your own safety first. How did that patient end up lying on the floor in the middle of that collapsed building? Do I really think that I can rescue anybody from that fire? How could they possibly be alive? What happened to make that train go off the rails? And what other hazards are there? And where is that car that hit the truck? Is it sneaking up on me? So your safety is critical. When you first arrive on the scene, you have to make sure that the scene is safe. You need to consider all the various hazards. And while you can remember them any way you want, I find this little memory bridge pretty helpful. Fire is pretty obvious. Water would be water or any environmental hazards. Glass is broken glass, bent metal, or other debris that could hurt me. Gas, gasoline, or other hazardous substances. Sparks, electricity. And sharks are dangerous people or animals. I have a friend who is a paramedic in Cleveland. He went to a shooting, and a patient had been shot in the chest and the abdomen. There were about 12 police officers on scene in this apartment. And as he was kneeling on the floor starting to take care of the patient, he saw something blur into his vision on the right side, and now he's deaf in the right ear because the perp came back, pulled a gun, put it right beside my friend's head, and shot the victim in the head and killed him right there with all the police around. So you really need to be aware of what your hazards are from bystanders and perpetrators and other people who are around. You need to make sure you have body substance isolation in place. At a minimum, gloves. You will also want to consider splash guards for your eyes, safety glasses, possibly a mask if the patient has an infectious disease or there's a risk of aerosolizing all sorts of nasty stuff out of their mouth when you manage their airway, and maybe even a gown if there's quite a bit of blood. How many patients am I dealing with? If you're dealing with one patient, you may be able to manage them on your own if they're awake and alert and looking at you. If you find an unresponsive patient, at a minimum you're going to need an additional person. And if you find more than one patient, we'll start calling for your resources. And when you need them, call for them now. So once you've assured that your scene is safe, your body substance isolation is in place, you know how many patients you have, and you've asked for additional resources, you start to approach the patient. And you can do something of an assessment while you're approaching your patient. You can assess their mental status. AVPU, AVPU, stands for Alert, Verbal, Painful, and Unresponsive. And it's a question of the patient's mental status. Are they alert and awake and aware? Do they respond to verbal stimuli, either by talking to you or at least moaning or grunting? Do they respond only to painful stimuli? Pressure on their nail bed, rubbing on their sternum, pinching an earlobe or the arm. And the idea is not to leave marks, but to apply a sufficiently noxious stimulus that anyone who's reasonably in decent health and whose brain isn't in some way impaired will wake up, or if they don't respond at all, they're unresponsive. And so as you're approaching a patient, you can assess whether they're alert or at least respond to verbal stimuli, and only after contact can you see if they respond to painful stimuli or if they're completely unresponsive. This is where you reach your first decision point, and the decision is essentially, do I need to do CPR on a patient or not? If your patient responds to verbal or painful stimuli, or if they're alert and talking to you, clearly they have a pulse and don't need CPR. But if your patient is unresponsive and they're either not breathing or they have very abnormal gasping breathing, or what would be called agonal breathing, clearly ineffective breathing, then you need to activate the emergency response by calling for additional help, requesting an AED, and starting CPR. And if you don't have an airway barrier device immediately available, do compressions only. If you do have a device, either one that you're carrying or you've got a first aid kit that has a barrier device, then you do compressions at a ratio of 30 compressions to 2 ventilations. Although you don't have to do the ventilations, at least for the first 10 minutes or so. You can just do compressions if need be. You apply an AED, and if it tells you to shock, you shock the patients, and you continue this cycle and recheck the patient every 2 minutes. Those patients are dead. You may get them back, and if you do, that's a wonderful thing, but there's nothing particularly exciting about taking care of them in the sense that you're doing something very rote. You're doing CPR, you resuscitate for 20 minutes. If you're not successful, it's very unlikely you'll get the patient back. It's the patients who are not in cardiac arrest that are much more interesting, particularly the very sick ones, because those are the ones that you have a chance to save their lives and to keep them from going into cardiac arrest. So someone who's alert or responds to verbal or painful stimuli, or who's unresponsive but breathing pretty normally, those people you take a different approach. And you use the X, A, B, C, D, E, F mnemonic to do that. So now you're doing your initial assessment and immediate interventions. And if you go all the way through here and don't have to perform any interventions, this should really take you less than a minute. But the X stands for Identify and Control Exsanguinating Hemorrhage. Good research from the Iraq War, as well as tactical emergency medicine, has identified that people will die of active arterial bleeding. If they're spurting bright red blood, they'll die from that before they'll die from a problem with their airway or breathing. So you need to control that active, life-threatening, exsanguinating bleeding immediately. Then you go on to A, check the airway, make sure it's open and adjust it, head tilt, chin lift, or jaw thrust if you think about trauma. And if you're thinking trauma, C-spine stabilization. Once the airway is patent and supported, then you need to check breathing. You make sure that their breathing is adequate, and if it's not, then you need to support their ventilation. Your next step is to assure that they have a pulse. If they were alert, responsive to verbal or painful stimuli, or unresponsive but breathing normally, then chances are that they have a pulse. However, this is where you really confirm it by feeling for a carotid pulse or a radial pulse or a femoral pulse. And the radial pulse is the first one you lose when the blood pressure drops, then the femoral pulse, then the carotid pulse. What you'll assess will probably depend where you are relative to the patient. If their wrist is easily accessible, you check a radial pulse. If you're closer to their groin, you check a femoral pulse. If you're up by the head, you're going to check a carotid pulse. And you look and see if there's any non-exsanguinating external bleeding, and you control it at this point. D is assessing disability, which is their mental status. You've already partially done this to decide to take care of them and how you're taking care of them, but again, more formally go through and think about, are they alert? Do they only respond to verbal stimuli, painful stimuli, or are they completely unresponsive? E is exposing the patient. So you expose the patient to look for further injuries, illnesses, other findings which explain what are going on with the patient. It depends on the environment you're in. It may not be safe to expose the patient, particularly if you can quickly get them to a sick bay, but you may need to completely expose them if you're going to be with them in that place for a while. And then once you've done that, you need to protect them from the environment by covering them back up. And finally, with F, you're finding other clues on scene. Medical alert tags, clues on the scene, multiple bottles of empty alcohol, drug paraphernalia, or evidence that the patient fell from a height in a way that you can guess how high that was. And if there's bystanders, you get a rapid history from them. Hey, what happened? Once you've completed your initial assessment or primary assessment and you've done your interventions, then you can move on to your secondary assessment. And this should typically take less than 10 minutes. In fact, oftentimes it'll take less than 5 minutes. I never would have believed this before I started medical school, but when I see a patient now complaining of chest pain that I think it's related to their heart, I'm typically in the room with them from beginning to end for less than 5 minutes to do my initial history and physical exam, because it's all very focused. So if you've got an alert or verbally responsive patient, then you can get a history from them. You can do a physical exam. If they only respond to pain or they're completely unresponsive, then you want to check vital signs. Definitely pulse, blood pressure, and respiratory rate. You also want to, at some point, check a temperature and oxygen saturation, but to do that, you need to have a thermometer and a pulse oximeter. So if you don't have those devices immediately available to you, you may not get those findings right off. Now to get the blood pressure, obviously you need a blood pressure cuff, so you need to make sure that somewhere in your work environment you have a blood pressure cuff immediately available to you, either in a first aid kit or in the jump bag or aid bag that's going to come to the scene, either by you or that someone else will bring, or you may need to take them to the sick bay to be able to assess them there to get their blood pressure. You want to do a head-to-toe evaluation if they only respond to pain if they're unresponsive. They can't tell you what happened. You need to go over them and look for clues. Once you're in the sick bay, or if your glucometer, your blood sugar meter, is in the jump bag, you do a finger stick blood sugar. And you do that as quickly as possible because low blood sugars can do brain damage very quickly. And so if that's the problem, you need to get that blood sugar up quickly. If you can't check a blood sugar and you have any reason to believe the patient is a diabetic, they have a medical alert tag, they have small bruises on their stomach from where they give themselves insulin injections, or they have a little pump on them with a catheter that goes under the skin into the abdomen, that's an insulin pump for them, then you need to give them some sugar, either some oral sugar, and if they're completely unresponsive, lay them on the side, rub it on the side of their cheek, or rectal glucose. Both of those absorb well, and you want to prepare to transfer your patient to the sick bay. Please complete the knowledge assessment and make sure that this is all clear to you. And if you have any further questions, please contact your professor. Thank you.